Starting. Yep.
Great, thanks everyone. I know we're all still getting to know each other as a group. So if it's okay, could we go ahead and just do once again, sort of a round of introductions and let us know who you're with? Adrian, would you want to call people out?
Yeah, happy to do that. Nikki, you want to go first?
Sure. Nikki McCann, I'm Vice President for Provider Payer Transformation with the Johns Hopkins Health System. Happy to be here.
And Dr. Hepburn?
Brian Hepburn, Chief Executive, National Association of State Mental Health Program Directors.
And I'm just, sorry, working my way down the list. Sue?
Hi, Sue Doyle, Local Behavioral Health Authority, Carroll County.
Dr. Jones?
Hi, good evening. Aaliyah Jones, Deputy Secretary of the Behavioral Health Administration.
Dr. Callahan?
Hi, Chuck Callahan. I am the Vice President for Population Health, University of Maryland Medical Center, and representing University of Maryland Medical System.
Elizabeth? You're listed as Natalie, but I know you are Elizabeth.
Oh, Natalie too, that'd be fine. I'm Elizabeth Crom, and I'm the Vice President of Population Health Advancement at Howard County General.
Thanks. Carl?
Good afternoon. I'm Carl DiLorenzo, Policy Director with the Howard County Executive, Calvin Ball.
Katie?
Katie Rouse, Executive Director of On Our Own of Maryland, a peer-run behavioral health education and advocacy network.
Maria?
I'm Maria Tilden. I'm EVP for Government Affairs and Public Policy at Care First.
Linda?
Linda Rain, CEO of the Mental Health Association of Maryland.
Dr. Moran?
Ryan Moran, the Assistant Vice President for Care Transformation at MedStar Health for the Baltimore region.
Sunny?
Hi, Sunny Schnitzer, Deputy Mayor for Public Safety, Baltimore City.
Stephanie?
Hi, I guess you mean Stephanie House. So
Yes.
if so, hi, I'm Stephanie House. I'm currently the Chief of the Bureau of Behavioral Health for Baltimore County, which is part of the Department of Health, and also the Local Behavioral Health Authority. So hello.
Sharon?
Hi, Sharon McFarland, Vice President for Population Health for LifeBridge Health.
Mark?
Hi, I'm Mark Orlowski. I'm with the Howard County Police Department's mental health section.
Great. And if we could just quickly do BHSB staff, many of you already know me. I'm Adrian Bridenstine, Vice President of Policy and Communications. Krista, if you are available. I'm going to do Krista for her. She's in transit. Krista Taylor is our President and CEO. Dan? Rabbit? I see there's more than one Dan.
Hi, Dan Rabbit, Policy Director for the GBRICS initiative based out of BHSB.
Kristen?
Kristen Emerson, Operations Specialist.
And Diane, I consider you honorary BHSB.
Hi, I'm Diane Stolenwork, and I'm a consultant to BHSB and the GBRICS work.
I believe that's everybody. Nikki?
Great, thanks, Adrian. Great to see everyone. I did want to note we had a slight change in the agenda. Our Vice Chair Andrea had something come up, and she may be able to join us later. So I think first thing on the agenda is 988 Nationwide Suicide Prevention Hotline. And I think it's important to get a briefing on this issue because it's an initiative that will impact GBRICS. And it is for those of you who are not familiar with 988, I believe, we've talked about it at a very high level, in various GBRICS meetings, but it's a nationwide phone number for the suicide and crisis hotline. And it's really important as a council that we understand the changes that will be coming as a result of 988 and plan for how they will shape the future of GBRICS. So with that, I will turn it over to the BHSB team to talk, and Laura.
Yeah, so we've got Laura Evans with us, who is the program manager of national and state policy from Vibrant Emotional Health. Laura, I'm gonna unshare my screen so you can take over. And I'm gonna turn it over to you.
Perfect. Well, thank you all so much for having me. I'm with Vibrant Emotional Health, and Vibrant serves as the administrator of the Lifeline and has been administrator since the Lifeline's inception. And I just wanted to make a little note about the picture. You can tell we've been in COVID for a long time because I was very blonde when that picture and headshot was taken, and now not so much. Haven't been able to get to a salon, but hopefully there's a light at the end of the tunnel. I am going to share my screen. Okay, and are you all able to see it clearly? Okay, perfect.
Yes,
okay,
we can see it.
Perfect. So I'm calling this the 411 on 988 just because I hope to provide an overview of both the Lifeline and 988 moving forward. So I just wanted to start by saying that even though the Lifeline is a program funded by SAMHSA, the content in this presentation is not necessarily the views, opinions, or policies of SAMHSA, HHS, CMS, or any part of the US federal government. So with that disclaimer out the way, I just wanted to give a baseline for the Lifeline. The Lifeline was established in 2005. And before this time in 2005, really it depended on your county or state if you had access to 24/7 suicide prevention resources. And so the Lifeline was created to serve anyone, anywhere in the United States who could be at risk of suicide. And or their loved ones could call in and reach support, emotional support, and local resources. And it's all done through our national network of crisis call centers. And so these local call centers really serve as kind of the last public safety net for suicide prevention and mental health crises. Sometimes people think the Lifeline is one giant call center based in DC, very close to you all. But we have to explain to folks that the Lifeline is really a network. And so centers can join our network if they can meet our clinical standards. And then they tell us the area they would like to serve. And so we, once they tell us the area, we send them calls that originate from that area. And so this really is local crisis centers serving people who are typically engaging in other ways with the local behavioral health system. We have over 180 independently owned and operated crisis centers in our network, including 8 in Maryland, and kind of pulled out some from Baltimore County, including the Baltimore Crisis Response Network, the Baltimore County Crisis Response Organization, and the Grassroots Crisis Intervention Center that's based in Columbia or Howard County. So we're very grateful for the work that these centers do to serve people in crisis. All the centers receive a stipend for the work they do answering Lifeline calls, but that stipend does not come anywhere near paying them for the work that they're doing. So we're just so appreciative of all of the centers in the network. And so Lifeline routing works. So an individual can call our current telephone number, 1-800-273-TALK, and that will be the number until July 2022. And when they call that number, they'll hear a greeting. And the greeting essentially says, if you are a veteran or calling in regards to a veteran, you can press 1 and you will be routed out of the Lifeline system and taken to the VA system and their Veterans Crisis Line. You can press 2 to be routed to our Spanish subnetwork if you prefer speaking in Spanish. And if a person doesn't press 1 or 2, then that call is routed to their local crisis center. And that routing is based on their telephone number. And so once that call reaches the local crisis center for which is covering that area, then the local crisis center has 30 to 60 seconds to answer that call. If for some reason there is no crisis center covering that area, then that call is immediately put into our national backup network. The national backup network is a collection of roughly 9 centers across the country that have additional capacity. They receive an additional stipend to answer calls, just so that we can reduce the amount of time an individual may be waiting to connect to a crisis counselor. So again, if the local crisis center isn't able to answer in 30 to 60 seconds, or there is no local center providing coverage to that area, then they are routed into our national backup network. Again, you still have the same kind of clinical standards for the backup network, but you do lose that local connection of understanding the local stressors, understanding what the local resources may be, what are the kind of transportation options. It may read on the map that, oh, that's only a mile or 2 away. But if it was a local center, they would know, well, public transportation isn't really an option. So those are some of the connections that are lost when a call is sent to our national backup network. And we try to work kind of with state officials and the local centers to build capacity so that the calls aren't being sent into our national backup network. But again, this is not due to any wrongdoing by a local center. They're kind of making the best effort that they can. It is just a lack of capacity kind of at the state level to ensure that that call isn't being kept in state. So now if we shift to 988, and I hope I'm not dating myself too much with this Schoolhouse Rock reference, but I'm surprised how many students these days are not familiar with Schoolhouse Rocks or how a bill becomes a law. But essentially, advocates in Utah, have this great idea that we have 911 for physical health. We need to have a number, a 3-digit number for individuals who may be in emotional distress or in a mental health crisis to call. That's very easy to remember. 1-800-273-TALK, 1-800-273-8255 is difficult to remember if you're not in crisis. And so you can imagine if you are in crisis, it's even harder to recall. And so they really began the idea or planted the seed for the idea of 988. So they took this to their state house. And their Utah state officials, to their credit, this is a great idea. They started investigating it and then realized that this actually was an initiative better suited for the federal government. And so both the advocates and their state leaders took this to the Utah congressional delegation to say, this is a good idea. We want you all to introduce this. Well, the idea got to DC. And like many things that get to DC, there was a lot of disagreement about what it should be. So everyone agreed this was a great idea, but there was some disagreement among advocates and others around the number exchange. What should the number be? Should it be an in-11 number similar to 911? Or should it be a completely new number that started with 9 so that it could have that same parallels as 911? What infrastructure should it use? What would be the logistics of kind of such a hotline? Would we use an existing line like the Lifeline, or should we create something else? What could be the timeline for introduction? So there was a lot of debate, and ultimately there was the National Suicide Hotline Improvement Act, and that was introduced by Representative Stewart out of Utah, signed into law in August 2018, and it said, we need the FCC, SAMHSA, other agencies to study all of these issues and write a report to Congress, kind of basically making a recommendation. So that recommendation, oops, I'm gonna skip ahead here. That recommendation from FCC was that that instead of repurposing a number or using an in-11 number, like 211, 311, 411, 511, 611, they literally did all of the different variations. And they found that this is so important to have a dedicated line for mental health crises and suicide prevention that it needed an entirely new number that was distinct from the rest. And so they recommended that Congress move forward with 988. And so here is just a little quote from the FCC around why some of the other numbers weren't chosen. And again, kind of walking through each of the N11s, they really had a different purpose. And so, FCC said this is so important, we need a new number. They recommended that Congress they recommended that the commission itself initiate rulemaking to move forward with this. I'm gonna go back. Things are just a little out of order here. So then in August 2019, so one whole year after the Improvement Act passed, where they said FCC study this issue, the FCC released their report to Congress recommending 988. In December of 2019, the FCC initiated their own rulemaking to move forward with designating 988 as the number to reach the Lifeline. That's another critical piece of that report. It said instead of creating a whole new infrastructure, we already have the National Suicide Prevention Lifeline, which is tasked with suicide prevention, which also helps people who are in emotional and mental health crises. So we should use that existing infrastructure. So in December 2019, they initiated their rulemaking. That rulemaking became final in July 2020, where they said, telecom providers, you must route all calls that are dialed 988 to the Lifeline. And so that is a by deadline. So telephone providers have by July 16, 2022. We've already seen some of the wireless providers like T-Mobile, Verizon, US Cellular, AT&T, they've made this operational so their subscribers can dial 988 and reach the Lifeline. We are continuing to communicate to folks to call the full 10-digit number and not promote 988 just yet because it's not widely available on landlines. Folks may have smaller cell phone providers that haven't made that switch. And so in order to prevent any confusion, we are waiting till that July 2022 date before well, I shouldn't say that exact date, but as we get closer to that date, we'll have more promotion so that folks know that it will be ready. And then in this past April, the FCC released their report on geolocation because as I mentioned, the Lifeline routes calls based on your telephone number, which may not always correspond with your physical location. And so in order to have that physical location information so that we can route you to the closest crisis center based on your physical location, we need FCC to provide Lifeline with geolocation information. So that report was released last month, and essentially the FCC says, agreed, geolocation information is very important, but there are, like the Lifeline or the Suicide Prevention Improvement Act, there are still many parts that have to be worked out. So they recommended the formation of a working group to help work through some of those logistics to ensure that we're protecting privacy, but also getting the needed information. And then they also released or had a commission meeting regarding texting to 988. So their original order in July 2020 did not include texting. And so because we know folks text the Lifeline, you can text the Lifeline currently, the 10-digit number. We want to ensure that folks can also text to 988. And so that's under consideration. So I'm going to go back because I had them out of order. So while FCC was doing all this work, Congress decided to catch up, right? FCC's moving along. So Congress said, okay, we'll start acting. So in October of 2020, Congress and the president signed into law the National Suicide Hotline Designation Act. And so the Designation Act had a couple of provisions. One, that the FCC must designate 988 as the 3-digit dialing code to reach the Lifeline. Well, this was signed in October. FCC had already done it in July. So check, that was already done. Their FCC had to complete a 6-month study on the feasibility of providing geolocation information. We saw that did come out in April, so that's also completed. SAMHSA, the VA, had to complete a 6-month study on what federal resources or funding was necessary to build out the 988 infrastructure. That you see is still pending. There's a little cog there. Even though the 6-month mark was up in April, we're still awaiting SAMHSA's report. Although we know that there's been some transition that the agency has experienced. SAMHSA also had to complete a study on how can we better serve high-risk populations. So we know LGBTQ youth, rural individuals, Black males are at higher risk of suicide than the general population. So how can we better serve those groups? Lifeline and Vibrant is very proud that we work closely with various stakeholders, including the Trevor Project, to incorporate training for crisis counselors. But 988 really does serve as an opportunity to kind of reimagine and revision how crisis services are delivered, particularly to marginalized communities. And so this is, I think, a very exciting piece that I know I'm looking forward to see, how we can better serve those groups. How can we build in equity from the beginning and not just add it as an afterthought? Then this, the kind of last provision here, I think is most exciting for states because it says that states are not prohibited from levying a fee on mobile and IP-enabled services that is to be used for 988 crisis centers and related services like crisis outreach and crisis stabilization. So this is very important because the Designation Act did not appropriate or authorize any funding because that's what they need the SAMHSA report for. So this provision allows states, much like 911 is paid for, to levy fees associated for 988 use. Now, the federal legislation did call out mobile and IP-enabled services, but in conversations with the telecommunications industry and with Congress, the intent wasn't to limit the fee to just those two items. States have levied fees for 911 on landlines, so that wasn't an issue of authority. There may be some question of authority around mobile and IP services, so that's why that was specifically called out in the federal legislation. It wasn't to deny states the opportunity to levy a fee on other services that are related to telecommunications. So if we think to 988, we're still waiting the reports from SAMHSA, but Vibrant, as the administrator of the Lifeline, kind of thought through what should 988 and the Lifeline of the future provide. And so we see that as basically essentially the same mission that Lifeline has now, serving as the mental health safety net, reducing suicides and mental health crises, and helping folks on a path to emotional well-being. And also, again, our mission serving everyone in the US and the territory so that they have immediate access to Lifeline resources, no matter where they are. So I've heard both everywhere. Well, I think I prefer anyone, anywhere, anytime. And I think that really speaks to the mission of 988. No matter your county, your state, your zip code, these services should be available to everyone in any modality, calls, text, or chat at any time, 24/7. We also kind of built out three main themes for the Lifeline of the future, and that includes universal and convenient access. So again, people are aware of 988 just as much as they are of 911, and kind of the scope of services that you will get when you call 988. Much like when you call 911, you have the option for EMS, fire, and other services. Again, resources for self-help, so folks can move along that continuum, develop coping skills available in the various modalities, and then a very timely response. So again, that folks aren't waiting when they're in crisis. High quality and personalized experience. So to the extent that every crisis is unique, we also want to make sure that we are building out and having more standardization across the line that is in line with best practices, but also tailored to their unique experience and the unique stressors that may be in that area. And then as appropriate, connecting folks to other resources and follow-up services, again, that reflect the local community. We want to ensure that we are, again, helping folks stay in their communities. We're hoping to divert from the inappropriate use of jails and or hospital emergency department use for people who are in crisis. That's not always the most appropriate place for folks to go. We want to connect with local public health and safety services. So currently all Lifeline centers have a protocol for connecting a call to 911 if that's necessary. But sometimes the local PSAP or public safety authority doesn't always know about their local Lifeline center. And so that information doesn't flow to the center where they may be best able to kind of help on an kind of emotional crisis, mental health crisis call. And so again, we want to make sure that we are partnering. The goal is not to make public safety out to be a villain, but we're all here to serve individuals in crisis. So we want to make sure that we are connecting with those services. And then again, follow up services as necessary for folks. So what does that look like? SAMHSA, and you all are likely familiar with this, has outlined several elements that they think are part of a crisis system, and this is part of their national guidelines for behavioral health care. So the crisis center, or having someone to talk to, and again, that could be the Lifeline centers through 988. A mobile crisis team, or having someone to respond. Again, that is well-trained in mental health crises. That's an appropriate response mechanism. And then crisis receiving and stabilization services, having somewhere to go that is not jail, that is not an emergency department room, that can be costly and not the best place for an individual in crisis. And so these are the core elements, and SAMHSA has also identified the crisis center as being the hub for connecting an individual in crisis to those other services so that we don't lose track of anyone along the way. And we're really moving from a fragmented system into a system where we can thoroughly track kind of where a person is in the continuum. So to help with 988, this is a lot to take in. Vibrant had issued 988 planning grants to states, proud to have Maryland part of the planning grant. 46 states received the grant. It was not competitive, so if you applied, you received one. We really wanted to help states think through these 8 planning grant considerations. So one, how can you ensure that you have 24/7 statewide coverage for 988 calls? As I mentioned before, the crisis centers tell us what area they want to cover. So there, in some states, there are wide gaps where there's no coverage for Lifeline calls. And so, it's really up to the state to ensure that these calls are going to come in starting July 16th, 2022 via 988. They're coming in now. So we need to make sure that there's complete coverage for a state at all times. Diversified funding, as I talked about the fee, that is just one mechanism for providing funding for the crisis centers and related services, but it's really going to take kind of all of the different players, the states and the federal government, public insurance, private insurance at the table to ensure that we are kind of billing for services where appropriate, levying the fee to pay for services that aren't billable, but that we are not going through this boom and bust cycle that depends on a state kind of fiscal outlook to have funding. We also have volume growth projections. We'll talk about that a little bit later. Vibrant has done the work with several consultants to estimate what we think is most likely going to be that the growth of the Lifeline in calls, texts, and chat. And this is to help states plan for that anticipated volume growth. And again, states, as they are making these decision points and making sure that they're incorporating our operational, clinical, and performance standards into the requirements that they may have for centers to do this work. We want to make sure that the center, whichever centers are kind of designated by the state, can also meet our clinical guidelines, because that's very important. Again, stakeholder planning groups to ensure that everyone's at the table is very important. Again, connecting with 911 and local public safety communities, providing follow-up services that are in line with best practices and guidelines. And then again, I think most importantly, consistency in public messaging around the services available for 988 and just building awareness. I'm going to shift a little bit to the legislative side. And we do have model legislation for a connected crisis system under 988 that was put together by NASHBID with input from other mental health organizations. And it really took a look at the SAMHSA best practices guidelines and then put that into legislative form to ensure that we are providing the best care for folks. And so that includes designating at least one or more centers to serve as the hub for 988 contacts. And again, this could be one center that serves the whole state or regional centers. So basically the centers now, the 8 centers serve as regional centers because they are serving a portion of the state. But it's very important that the state, again, ensure that there is complete coverage and that there are no gaps. Again, statewide or local mobile crisis team utilization so that the centers are able to activate or deploy a mobile crisis team without having to transfer that caller and that caller have to say their story all over again. We want to make sure that the crisis center, and the crisis call counselor can utilize the public or the mobile crisis team without having to jump through extra hoops, which would only serve to delay care. And then funding to establish, if a state doesn't already have, crisis receiving and stabilization services. Again, we want to divert from folks going to jail because there's nowhere else to go or just sitting in a hospital emergency department, which may not be the best place for them. And then the model legislation also includes provisions around the creation of a 988 fund. And so this fund would essentially allow any revenue generated by 988 fee, any state appropriations, any federal appropriations, any gifts to be allocated in this fund, continuously appropriated for the 988 crisis centers and those related services. So this fee is a really important part, I think, to ensuring that there is sustainable funding for 988. We can't meet the vision of 988 if we don't have a way to pay for it. So I wanted to pull out from the federal legislation the actual fee language because this has been up for debate in some states. But as you can see here, the federal government really kind of outlined the 2 purposes of a 988 fee. One is for the crisis call centers, ensuring that they have capacity and that we can route calls there. And I think there's a reason that Congress had them at A because it's so important as that large front door that 988 crisis centers in the Lifeline Network are well resourced. Once that number becomes just as well known as 911, it's important that we also have that capacity behind it. Otherwise, we are handicapped out of the gate. And then B, which is also still really important because we do need to have other services kind of crisis array connected, is to ensure that crisis outreach, crisis stabilization services are connected, so they're responding, and so this funding can be used for that purpose. Sometimes, we hear a little pushback from the telecommunications companies in other states because they're really kind of focused on ensuring that the fee only supports the local crisis centers. And we believe, because there is no wrong door for folks to enter, even if the 988 or the need for a mobile crisis team doesn't come from the deployment by the crisis center, the 988 crisis center, let's say, another entity deployed it, once that the billable portion, if there's anything left after the billable portion, we do believe that the fee could support it as long as that service is an option for a 988 crisis center to deploy. So again, we want to make sure that the continuum is connected, it's kind of coordinating, but we also don't want to have to parse out, well, somebody else activated this crisis outreach team, so that can't be reimbursed with the fee. As long as they're all connected, we believe that the federal legislation allows the states to use the fee for that purpose. And again, we talked a little bit about how the fee could be applied. I have the different types of phone options here. So the telecommunications companies have told us in conversation that they want this fee to be competitively neutral. so that it applies to both the cell phones, VoIP, IP services. It applies to landlines. It applies across the board. We've seen in New Jersey and in New York, they have exempted cell phone users who are a part of the Lifeline phone program. And the Lifeline phone program is not related to the National Suicide Prevention Lifeline, but they're commonly known as the Obama phones. So if you're a low-income individual, you can qualify to have kind of a free phone. And so those two states have included in their legislation provisions that exempt those users from having to pay a fee. And again, I guess I should note that the 988 fee setting, and we'll talk about kind of different ways that states can determine what the fee should be. But this is outside of the provisions in the federal legislation. There's a lot of state authority to decide here. So there's a lot of different decision points that a state can make when it comes to a fee. One of the things that was a part of the federal legislation was that outside of those two purposes, anything else could be considered diversion. So if you generate 988 fees and you instead of using it for your crisis center or your mobile crisis teams, you use it to backfill your state budget, that's diversion. That can get you in trouble. If you collect 988 fees on the same line as a 911 fee on a cell phone bill, that's fine as long as you don't put those you don't put those funds into the same account. That became an issue in Virginia, where initially they didn't establish a 988 fund in their legislation, the first draft of it, and the FCC said, well, if you put it all in the 911 fund and then use some of it for 988, that's actually considered diversion. You could put your 911 grant at risk. So again, they can be on the same line within a cell phone or other phone bill, but you don't want them commingling the actual money. And so FCC guidance is available on this. They worked very closely with Virginia to get to a place where the fee wasn't considered diversion, and that legislation did pass once the FCC kind of provided some guidance. So I always just let folks know that they are there to help as you set this fee. So now we'll talk about what the fee should be, and there's different philosophies on what the fee should be. So for some communities, they think that because the 988 fee is very similar to 911 fee, that one place to set it is kind of just whatever the 911 fee is. And so the 911 fee across the country has generated over $3 billion, a billion with a B, in 2019 alone. So in that 1 year, it generated over $3 billion. Now we can imagine what we could do with that kind of money year over year. In Maryland, according to the report filed by the FCC, the Maryland 911 fee is $1.25 total for everything except for prepaid phones. The prepaid phones pay 60 cents. And of that $1.25, 50 cents goes to the state for everything but prepaid, and 15 cents of the 60 cents goes to the state for prepaid. So postpaid, which are the monthly accounts, the state gets 50 cents, and then for prepaid, it's 15 cents. And this is all according to the FCC. Every year they release reports on 911 fee diversion and fee revenue. In Maryland in 2019, there was over $56 million generated by 911 fee. So again, if we take that 56 million and we portion that to 988, crisis centers and crisis services, I'm sure there's a lot that you all could do with that money. And so I bring that up to say, again, mental health, behavioral health seems to go through this cycle of traditionally not having a lot of funding, and a 988 fee is one way to kind of help move out of that. It's not meant to supplant existing funding, but certainly added as a braided approach with state appropriations, federal dollars, can help support these services. So I have a link here. Vibrant, as part of the planning grants, has taken a look at 988 call, text, and chat volume, along with our estimates of what it takes kind of for centers to have additional capacity and operations to meet that. And the next slide I'll show kind of goes more into the cost. But some of the things I'll note here is that this does not include those other pieces like crisis stabilization, crisis receiving, mobile crisis teams. This is just solely looking at what would be needed from Vibrant's perspective for the crisis call centers. We also factor in some additional KPIs, such as answering calls within 20 seconds or less. So again, that's a little bit different now, where it's about 30 to 60 seconds for a call before it goes into our national backup network. This also includes paid staff. Some of our centers use volunteers, and so we believe that folks should use paid staff just so that we are providing sufficient training, we're retaining folks, we're factoring time for debrief and coaching. All of that we think goes into meeting the vision for 988. This is Maryland's 988 first year cost model that was generated by Vibrant along with our consultants. I'm not going to go too heavily into this because this is not my world, but I think it's really important that, well, I'll say that as part of the planning grant, the grantees have access to this information, but I think it's important to also include this information as you're thinking about what the fee should cost, because this is what we think it should cost for being that large front door, having the capacity to answer all the volume. So you'll see that there's kind of under estimated cost per contact. We have what we estimate will be the volume for the first year. And again, Vibrant modeled out low scenarios, moderate scenarios, and high volume scenarios. So we think that in that first year of 988, it'll likely be a medium volume scenario where folks are still getting kind of acclimated to the idea of 988. And there are two columns here. There's an independent column and a centralized column. The centralized column just essentially means not that you have one call center, but you are building in efficiencies in the routing that centers are serving as backup to each other, so that it is so that call has a place to go, maybe one or more times before it goes into the backup center. So independent is more closely aligned to how things are now versus centralized, which kind of builds out some of those efficiencies that we've been talking about. And so again, this kind of provides the cost for center level operations, including staff. This does factor in that the call centers do have other lines of business, but for 988, we do have dedicated staff. You'll see dedicated personnel to ensure that, again, we're just meeting these best practices. And then taking a look kind of countrywide at the different legislative efforts, we do have the states that are in yellow that either have 988 legislation or resolution signed into law. So Virginia was the first state. Their session is only 30 days, so they were in and out. And they have a 12-cent 988 fee on monthly accounts, 8 cents 988 monthly fee on prepaid accounts. They did not include the other provisions around coordinating the various components because they were already doing work on that. They have their Marcus alert system. They were already making those efforts, so they didn't incorporate that. Again, the model legislation is completely up to a state to tweak based on what they need. Next, we saw Utah pass legislation. Both Idaho and Alabama have resolutions. In Alabama, that is a study committee, so they will study this in their interim. Indiana, their bill was just signed into law. Their bill actually became a really big omnibus that includes kind of leveraging Medicaid for some of these services. Washington is in orange because their legislation is on their governor's desk, and they took a very expansive view. They kind of included a lot around who can serve on the mobile crisis teams. They're requiring their private payers, in addition to the public payers, to reimburse some of these services. The other states are in green because they're still moving through their process. They're at various points, but they are still active. And then Montana, the legislation is not active there. It did not get out of committee and is likely considered failed for this session, but I know they're thinking of bringing it for next session. So just some things as we look ahead. Of course, we have federal appropriations. We saw in December that for the fiscal year 21 budget, there was an increase in the mental health block grant. That was a 5% increase in the block grant that was set aside for crisis services. Some states are using the entirety of that set aside to support their crisis centers, to build out capacity. Others are using it to build out mobile crisis teams. We are waiting to see what that infrastructure study from SAMHSA looks like, if there will be federal appropriations for that and for the administration of the Lifeline. We look forward to more rulemaking from the agencies, particularly what FCC will do on texting, if they will finalize that rule or finalize that effort. And then, of course, the work that you all are doing to, in the planning grants and otherwise to, connect your services if you choose to levy a fee. I think that all goes into the rollout of 988. So that was a lot of information. I tried to go through that as comprehensively and quickly as I could, but here's my contact information if you have any additional questions. And so I'm going to stop sharing and check out the chat to see if there's anything there.
Great. Thanks, Laura. That was an amazing presentation. And I feel like, so much of the work that we envision in GBRICS really aligns with 988. When you're looking at the planning, I feel like there's really some great synergies there. I think one question that you might be able to answer comes from Chuck Callahan, related to Georgia and Arizona, since they already have this. Is there no legislation there because their system's already robust, or is that something that's in the works? Do you know?
My sense is that their systems have been doing this for a while, so they may not have legislation, although never say never when it comes to elected officials. But Arizona has a very comprehensive Medicaid waiver. Georgia has been doing a care traffic control model for some time. So I don't imagine those states will introduce legislation this session.
Okay, thanks. Other questions? Does anyone else have questions for Laura? While we wait for the questions to come in, and either put them in the chat or feel free to raise your hand. Laura, have you been briefed on our GBRICS proposal, or have you been given a high level overview of our? So from your perspective, how do you see 988 and GBRICS coming together?
Well, thanks. Yeah. So Adrian did provide an overview of the GBRICS effort. I think this, as you mentioned, the goals are aligned with what 988 we've articulated for 988. I think the devil's in the details, and we're always interested and happy to provide technical assistance to folks, and just to ensure that our intentions actually do meet for the people that we're serving. I don't know if that's as helpful.
No, that's very helpful. Sorry, I was on mute. Thank you. I see Linda Raines has a question. Linda?
Yeah, I just had a question about the fiscal model. I think many of us saw the report that SAMHSA released last year that recommended HCPCS codes that could be used for the call center, mobile crisis stabilization. And so I'm just wondering how those funding sources fit into the strategy, and if there's been an analysis of what would be covered by the fees that you mentioned, and what would be billed to both Medicaid and commercial insurance for the services.
I am not aware of any movement. Now, there could be conversations going on kind of at the federal level regarding coverage, and each state kind of. I'm also not aware of an analysis holistically of activities around public and private payers for coverage outside of the Washington effort to have private coverage.
Adrian, maybe we could share that SAMHSA report with everybody. I think that would be helpful to take a look at.
The best practices report?
Yeah.
Yes, that's on the GBRICS webpage, but we can send that around to the council.
Great.
A couple questions in the chat. Laura, what does a state risk if they do not pass authorizing 988 legislation? And if, sorry if you had mentioned this in your presentation, I missed it, but is there a time frame by which a state has to pass the enabling legislation?
So there's not a time frame that a state has to pass the legislation, but we do know that that July 16, 2022 date is fixed. And so starting on that date, calls will come in. And if there is no change, then it will operate as it does now. And that means that the individuals from Maryland would not have as connected services as folks across the country or other states that have passed that. Including if there is gaps in coverage for the state, those folks would be sent to the National Backup Network, where they are again waiting a little bit longer and losing that connection. So this is a real opportunity, and it would be unfortunate if a state did not leverage this opportunity to kind of remake the crisis continuum to better serve folks.
Thanks. Another question in the chat. What is the requirement versus best practices regarding physical office location versus virtual location for call centers, centralized versus independent?
So we actually have, as part of the planning grant, our standards training and practices team can provide some TA on what would be a best practice. I'm not a clinician, so I don't want to get too far ahead of myself, but I think one of the things that we saw in COVID for centers that leveraged volunteers was that sometimes, the volunteers, if they were virtual, they felt uncomfortable taking a call in their home. There wasn't anyone there to debrief with or to provide coaching. And so that led to shifts being missed. And then again, more people being sent to our national backup network and losing that connection. So I think it's important, as we outlined, to have paid staff to ensure that we are providing that coaching, we're providing debrief time, just best practices to retain the workforce. So I'm not exactly sure what's, kind of the physical office and virtual office, but and I think that's better suited for our STP team, and happy to connect folks. But kind of what we saw with COVID was that it just wasn't as, the experience for the volunteers just wasn't as kind of conducive.
Other questions for Laura? Writing 988. No other questions. Well, Laura, thank you so much. This has been incredibly helpful. Adrian, did you have a question? You look like you were about to jump in there with a question.
Actually, it looks like Maria just submitted a question through the chat. Do you anticipate states adjusting the 911 fee to make the 988 fee more palatable? Is that even possible?
Yeah, that's a good question. And that's one of the ways that Virginia got their fee increased. In addition to levying the 12-cent fee for 988, they also took that opportunity to increase the 911 fee at the same time. That was their fee in Virginia is set by statute. So there's no kind of regulatory body that can adjust it year over year. And so each time they wanted to increase the 911 fee in Virginia, they had to have new legislation. And so that was part of the kind of process in Virginia, was to both increase the 911 fee and initiate the 988 fee.
Thank you.
Great question.
Any other questions? Last call. Okay. Thanks again, Laura.
Thank you all so much for having me. Have a great day.
This really is a great segue into the next topic, which is sustainability and policy opportunities. So there's, one idea we heard on the table for a potential component of sustainability for GBRICS for the crisis hotline for the call center. But one important consideration that we need to keep in mind as this program moves forward is that the HSCRC expects us to come together for a plan on sustainability. And there needs to be partnerships as part of this sustainability. We've got 5 years to move this forward. And so we really need to be thinking about this from day one. When it's 5 years from now, when the funding ends, what does this look like? How do we keep this this program going? Once we're proven a successful model, how do we keep it funded? So we expect that the GBRICS members and our council will use our power, our influence, our ideas, our networks to help come together around thoughts for sustainability. So we want to initiate that conversation today. We have 2 presentations. These do not cover all of the potential sustainability options that will come to us in the future. And I said, many of you may have your own ideas for sustainability that we'd want to bring to the council for consideration in the future. But tonight we're going to have Adrian present on some components of it, as well as Dan Laughlin from BRG.
Thanks, Nikki. So good. Let me just get my screen moving. So good evening, everybody. I thought to start the conversation, a good place to start would be to remind you all what we put in the GBRICS proposal for sustainability. So as a reminder, we submitted the GBRICS proposal to the HSCRC in July of last year, so almost a year ago. A lot has changed along the federal landscape and the state landscape since we actually submitted the proposal, and new opportunities are starting to present themselves, such as 988, which we heard. So all that is to say is what we've been saying from day one with GBRICS is we need to be adaptable and adjusting to the current political environment, the system change environment as we move forward with implementation of this project. But for a quick review, we put in the GBRICS proposal really for our sustainability plan is that we were going to change from a high level, really just change how things were done. And the way we were going to do this is through a couple of approaches. First, looking at standardization and lifting up accountability across some of the behavioral health crisis services that we put in the proposal. So mainly the call center, expanded mobile crisis team services, and then looking at expanding virtual and walk-in access services. We are planning some of that work now and doing some of that by one of the things we'll be planning to do, or 2 of the things we'll be planning to do with standardization, is looking to create standards for the comprehensive call center for how they respond to calls and deploy mobile crisis teams, for example. And then also developing standards for those mobile crisis teams, and then also looking at local protocols for that, recognizing that there are some strengths in our current local crisis services that we want to build upon and build it. But we also know that there needs to be standardization so that everybody's getting the same care across the entire region for the system. Those standards would ultimately be folded into contracts that the local behavioral health authorities have with our current behavioral health crisis service providers and potential new providers, as we would be issuing an RFP for all of the GBRICS services. So that's in some ways, related to policy, standardization, and then folding that into our contracts. The second piece would be looking at that broader culture change, which I know some of you have heard us talk about before, is something that is a work that goes beyond just the GBRICS partnership. But our goal with that culture change is really to shift our community's historical over-reliance on high acuity services like emergency departments, hospitalizations, and arrests, to really having people be more broadly aware of the community-based services that are available, like our comprehensive call center and like mobile crisis team services, and have them have a better understanding of what that means when a mobile crisis team would come out into the community to help you. The third component we put in the proposal is really looking at policy and advocacy, and recognizing that there are policies at the state level and federal level that would really need to change to support the GBRICS, some of the GBRICS initiatives. So looking at coverage and reimbursement changes at Medicaid and commercial insurance, but then also really developing a value proposition to show that there is return on investment by investing these, public hospital dollars into the public system. And then finally, we always know that there's going to be a need for additional resources. You heard Laura talk a lot about the need for braided funding to support the comprehensive call center. That's something that we know will always need to exist for our behavioral health crisis services continuum. So again, just as a refresher, I wanted to start with what did we actually put in the GBRICS proposal as our broad plan for sustainability. And now just starting the conversation on where are there some policy opportunities. Like Nikki said, tonight is just starting the conversation where we're going to present our 3 opportunities that we see now. Some of these opportunities were not available when we submitted the proposal. Some were things that we were considering. So you heard a lot about the 988 service fee. I'm not going to spend too much more time on this since Laura covered it pretty thoroughly, but I will say that many of us are looking at this opportunity to levy a fee to support the behavioral health crisis services continuum as a game changer. This is an opportunity to have sustainable funding, which is something that has not been available for behavioral health crisis services. Largely, behavioral health crisis services in the state of Maryland are funded by our state behavioral health administration. What you see on the screen is the legislation that gives states the authority to levy that fee. And we think part of the messaging, and I think Maria's question kind of alluded to this, is that allowing us to establish this fee, 988 fee, to support the behavioral health crisis services continuum is starting to move us in the direction where we as a community are starting to value our behavioral health crisis response in the same way that we value other emergency response services like our EMS, emergency departments, and fire. Like Laura said, there's already things that we can learn from. We can look at some of the other states that have already introduced state level legislation to enact a 988 service fee. As we know, Virginia was the first state to enact this legislation. We've learned a lot already from Virginia's experience. Some of that is not, one of those things is not combining their 911 and 988 tax. So that's something for consideration in other states as they move forward with, thinking about a 988 service fee. The second policy consideration is Medicaid reimbursement. So we know from looking at some other states that there's some other states have already been using their Medicaid programs to fund some behavioral health crisis services, and it really varies across the country. As many of you know, if you know one state's Medicaid program, you know one state's Medicaid program. They all kind of do it differently. What you see on the screen are some of the opportunities through existing Medicaid authority. And I know we have Trish Rowdy with us today who could talk in much more detail and extensively about all these options than I can. But state plan amendments, looking at our existing waiver authority, and then certified community behavioral health clinics, of which we have several in the state of Maryland, are some of the flexible options that states currently have through their Medicaid program. A new opportunity that is through Medicaid has come through the American Rescue Plan Act. So this is a piece of legislation that was passed as a result of COVID and that President Biden recently signed into law. But one of the exciting things about this is it does include statutory language that defines mobile crisis team services. It gives the state the option to cover and reimburse for mobile crisis team services. And like I said, there's specific statutory language defining what those mobile crisis team services look like. The other benefit is that there is a time-limited enhanced FMAT rate of 85% for mobile crisis team services. So that means the state can draw 85% of the matching funds for the first 12 fiscal quarters if they build this into the plan. So this is a new opportunity. Again, this wasn't available to us at the time when we submitted the GBRICS proposal, but something for consideration. The final thing is just about the American Rescue Plan. It does authorize state planning grants, which can be awarded by the secretary to the states for them to plan for, how they would build this into their plan and other behavioral health crisis continuum services. So those are,
Quick question before you move on to the next slide. For the statutory definition of mobile crisis team services, are we comfortable with that definition? Do we think that's consistent with I know that that team is meeting and defining what mobile crisis teams look like, that work groups in works, but are we comfortable with that definition of mobile crisis team?
I can tell you, I am. The definition seems to align with the SAMHSA National Best Practices document that was put out, really looking at having a team of a mental health professional, and then a range of other types of professionals that could be part of that team. So paraprofessionals, social workers, or nurses. But the helpful thing that I find in is that it's helpful for us as we think about developing our standards, because I think it's giving us a window into where, how we need to shape our mobile crisis team standards so that we can align with federal policy to set ourselves up for coverage and reimbursement if and when the state moves in that direction.
Thank you.
So this is all you're going to hear from me. I'm actually going to turn it over to my colleague, Dan Laughlin, to talk about HSCRC policy.
Adrian, and Adrian asked me to come in and just talk a little bit and set up the scene for what the HSCRC, the hospitals, as a potential contributor to the long-term sustainability of the program. So for right now, the HSCRC has allowed extra dollars to go into hospital rates specifically to fund this program. But at the end of the 5-year period, that money dries up, goes away as a funding source. And the hospital, though, has its main general incentive under GBR, or the fixed revenue model, remains the same. So in general, under our waiver model, a hospital can reduce volume, keep the revenue for the most part, and benefit from an expense reduction to create available funds to invest in population health. That's the general concept of our model. Any other state, if you are successful in your intervention, the ED visit goes away, you lose the revenue, you have to figure out a cost savings just to make up for the loss of revenue. So it's in your benefit, it's in your interest to keep that volume flowing, right? So in Maryland, hospitals can keep a portion of the revenue. So the revenue is unlinked to the volume. And their general value proposition is, again, we're making the intervention. The volume, the whole concept is that a behavioral health crisis ED visit is avoided, right? They keep the revenue. They benefit from the avoided visit from an expense perspective, and that's the value proposition. So the hospital is incented then to maybe have some funds available to keep to fund the program long term, because they are benefiting from the revenue and expense calculation. So it really just comes down to the general incentive. Once this 5-year period ends, the hospital, if we can show the hospital the value of these reductions in that they will benefit to a point to where it's their best interest to provide some funding to keep the process going, that's the incentive for the hospital. So Adrian, if you flip to the next slide, there are a few things that we can do to make sure that that value proposition is maximized. And the first is that while there is a general fixed revenue model in the state, there are still volume policies. And when, to say it simply, there's a set of volume in this state that we classify as avoidable, where there are maximum incentives to get it down, maximum, and then the revenue is protected. And so we classify chronic conditions, things like CHF, COPD, as avoidable. So a hospital has, $10 million related to X cases. They get to keep that $10 million, whether that is 100 cases or 50 cases. And that's where the value is maximized, is this specific policy identification of volume that is avoidable utilization, where the incentive to reduce it is maximized. And one thing that would be in the interest of this group is to get the behavioral health crisis ED visits and any visits, we have to think about what the exact definitions are, but to get those classified under that definition, so that you can, if it's not classified like that as it is now, a hospital may be at risk of losing some of that revenue because of the volume decline occurred, which may create some uncertainty for that hospital in terms of, I'm not quite certain that this is going to pay off for me as much as it it otherwise would because my revenue is at risk. So the first things first is to make sure that the revenue related to these volumes is protected so that when you reduce it, you maximize the impact. And the second thing is, once we get these things going, show what those, what the expense impact, the value to the hospital is of reducing those things, to show them that an ongoing investment is in their best interest, worth their time. So those are really the biggest things for the HSCRC right now is, one, make sure the revenue is protected at the hospital, and two, show them that it's in their best interest to make continued investments beyond the 5-year period.
Thanks,
So
Dan.
that, yeah, those are, that ends our presentation, Nikki. Welcome thoughts, questions, discussion.
You know, I think as we went in, as we put our application together, as the hospitals came together on this application, I think one of the points that was consistently made is that we, the hospitals, recognize the role that we play in sustainability if this model is successful, you know, ideally through that reduced ED utilization. But the hospitals cannot be the only option for sustainability. This really has to be a partnership and collaboration, you know, across multiple stakeholders who, you know, see the value in improved behavioral health crisis services. Any questions? Anybody have any questions for Dan or for Adrian? Let's see, I do see a question in the chat from Maria. Who would manage the savings realizes from the reductions? The hospitals are a separate fund. And Dan, correct me if I'm wrong, but I'm fairly certain that that, you know, this kind of the HSCRC has the ability to monitor that kind of those kind of savings.
They can monitor it. Right now, a hospital manages its own revenue budget. So, right. So it is up to the hospital, the health system, to manage whether that investment is made. There is some very too early emerging thought that if we do a great job in this system in creating, you know, volume reductions, that eventually there's going to be more like a pooling where we take it out of responsibility for the individual hospital and put it sort of back in the management of the state entity, but that's not true yet. Right now, it would be a decision by a health system to manage its own revenue base and make that investment.
Yeah, I'm just thinking about it from a population health perspective. And, you know, if it's truly successful, the notion that there would be, and I don't, whether it's an HSCRC fund or, to your point, redirected back to a federal agency, I mean, federal state agency, it seems to me that that might be an option on the long term.
Yeah, I think any long-term situation, it would still pass through the hospital like it does now. They would hold the keys to the decision to pass it through, basically, but it would still pass through to some entity that like BHSB is doing right now to manage the actual contracts.
Thanks.
And I would just add that the hospitals are not obviously the only beneficiaries of this program, right? So we've mentioned this when we were doing the proposal, payers, you know, public safety. There's a lot of people who would benefit if we get this right. And so we really need to consider that when you look at sustainability of this program. Just putting my 2 cents out there.
And what I would say, Sharon, is the hospitals might be the hardest to find the actual value proposition because, as I said, you know, there's increased throughput. It's a step function where you could actually have an expense savings calculation where you impact your staffing or something like that. So the easier one is to see that the payer, so if it saves the actual payment for the visit, and that gets spread across. So it's almost like a shift to a commercial payer. If our behavioral health visits are overwhelmingly Medicaid doesn't have to pay that payment, but it sort of goes on as a tax on everybody else who uses the hospital, and that spreads to a different payer. But The hospital value proposition in terms of, yes, we can guarantee the revenue is retained by classifying it differently, but showing, you know, it may be that throughput alone is a good enough reason to invest in these things, but it is a very big hill to climb for the hospital. So I would say maximize your other sources, like the payers, like some of these things we're talking about,
Right.
and
Yeah.
try not to be
Thank you.
entirely reliant upon the hospital.
Yep, I appreciate that because, you know, while the dollar savings, one for one, you know, is one thing, but when you look at patients in an emergency department, most hospitals typically, some do, but most don't have a special team of people just to care for these patients, right? They're weaved into our entire ED volume. So while it decreases workload, you know, you decrease behavioral health, now you're opening up beds for all of the other 100 patients that are sitting in your waiting room, right? So it doesn't necessarily decrease our cost.
I will say though that it's a fairly complex value proposition too, because it fits into your mission as well, right?
I'm not arguing. Yep, just so
Yeah.
you know, I agree with you. I'm just saying I don't want folks who aren't hospital folks sitting here thinking that hospitals have these tens of millions of dollars to throw back at things. We don't always, it doesn't always work like that.
And Sharon, to your point, to savings to others, if you look at the business case for the Crisis Now model, that model had demonstrated in Maricopa County in Arizona was the equivalent of 37 full-time police officers. Those were because they're no longer having to respond to the behavioral health crisis, and they can now respond to other public health emergencies, other public safety emergencies. So, you know, yes, you're absolutely right that there's opportunity for the savings to flow well beyond the hospitals.
So this is Trisha Roddy. I just want to make a comment that the Crisis Now calculator does show a tremendous shift from the hospital setting to other settings within the crisis service network. So it tends to argue a little bit differently there.
Yeah, I think there will be a big reduction in ED visits, and it's kind of a step function. So we need to monitor that and quantify that. That's kind of number two. There is I don't think we mean to say that it sort of falls straight into that what you said, Nikki. It's not the only. It's part of the equation, not the only part of the equation. And what we have to do is show that value quantitatively over time as we start, especially as we start to see the visit reductions, and get a good understanding of what that expense impact is at the hospital, because they absolutely should be held accountable as that equation works out.
And it might be interesting just for you all to look at the Crisis Now calculator in terms of levels and where the savings actually occur.
Linda, did you have a question?
Yeah, well, mine isn't a question so much as a comment. I just want to agree with some of the prior comments and suggest that as we're looking at financing, we need to look beyond Medicaid. We also need to look at commercial insurance. We need to look at parity in terms of, you know, someone has a healthcare crisis, their insurance reimburses for that. There's no particular reason why, if I'm commercially insured and I need an evidence-based crisis behavior health service, that should not be reimbursed by my carrier. We have some preliminary code analysis that's been done by SAMHSA around possible codes for these services. And I just think we should follow those developments and get behind them so we don't continue to dump all of the cost of this on government and the hospitals. So that's one comment. The other comment I wanted to make from Adrian's presentation is that as we're looking at standards, one of the things that leading the Behavioral Health Coalition I hear all the time is it's great that we're having all of this focus on crisis care, but we also need to be taking a good look at the unsexy side of care as usual and what happens in terms of general community-based behavioral health care And I think the one worry about a perfect crisis system is that if you don't have ready access to the services people need when they're transitioning or need an immediate service to avert a more expensive crisis care, then your system is not going to be as efficient in achieving its goals as you might like. So I wonder whether, as we're constructing standards and also data, if we're going to be looking at the reasons why a caller's needs were not met, despite having the best possible call center you could have, and where those pressure points are in the parts of the system that avert crises, and how we might better address those so that we can achieve the success that everybody wants to see.
Linda, I think you raised some great points, and I will say that in sort of coming together, and I know you were part of these discussions around the GBRICS proposal and what does this look like. That's an issue that repeatedly came up, right? That the crisis is not the only failing point in the system, and that there's a spectrum of care that people need that they're not necessarily getting. And if we focus only on crisis services, that's not necessarily going to allow for sort of downstream long-term treatment for individuals with behavioral health issues. And it's something we struggled a lot with in our conversations around this. And one of the things that was a challenge is that the RFP to this proposal was specific to crisis services. And so the continuum of care, as critical as it was outside the scope of this proposal. But I think you raise an excellent point in that this crisis program, this crisis model that we're putting together will only be as successful as the continuum of care. And so maybe it's worth discussing at a future meeting, who do we need to have around the table, and what do the conversations look like about the continuum of care? It may not necessarily be something that funding from this, the GBRICS can be dedicated to, but it is certainly critical to the success of GBRICS. So maybe we could make that a future agenda item and maybe even a potential work group. I don't know what others think.
Nikki, if I could just respond to that, I totally agree with you. And I think we don't want to water down the mission that we have here, because getting this system up and running.
There's a little bit of a lag, Linda. Maybe, here, let me mute myself.
Yeah, there. I think it's a tall order to do what we have in front of us just in the crisis arena. But what I do see is that typically we know we have those problems in the system, but we haven't had a good way to quantify them. And, perhaps through this call center, there's an opportunity to better pinpoint the data with some reliability that could point to things that this group wouldn't do, but that would help the rest of the system understand and respond to the gaps that inevitably a statewide crisis system could identify.
Agreed. And then to your other point about sustainability, I think we can all agree that this is a better behavioral health crisis system, benefits everybody. We are and that's why this group of stakeholders was convened to come together and consensus around what that looks like. So I think that there's an appreciation by everybody who's involved in this project that we all stand to benefit from a better, more robust, stable behavioral health crisis system. Other questions or comments on the policy considerations that were presented around sustainability? Any potentially new ideas that weren't necessarily presented today? And you don't necessarily have to raise them today, maybe in a future meeting, but any other ideas or thoughts?
I just wanted to share that on a different call related to the 988 implementation and call centers, the point was made strongly by the Lifeline Associated Centers in Maryland that the quality of referrals and ability to connect people with community resources that would help them, now that the crisis has been kind of de-escalated, that would help them stay well. Just speaking about how the importance of having locally based centers, independent centers rooted in their communities who become aware of all the other services and, you know, kind of know the quality of different services being available in the community. So I think as looking at the 988 plan and the efficiencies and costs that are achieved with a centralized center, but that part of the downside of that is folks just not being as intimately familiar with the specifics of the geography. So to the point of this being a, you know, having a mission, a greater mission about the impact on people's lives and not just cost savings, that those two things are really balanced. And I agree with Linda's points about if the continuum of care in a jurisdiction isn't robust, there's only so much we can do in terms of diverting crisis out of more intensive services if only intensive services are available. But I agree that that's maybe a working group or a parallel conversation with the other working groups that are dealing with these issues that we all are probably a part of, at least one. Thank you.
Other thoughts or questions? There was Diane had posted something in the chat around policy considerations for providers to participate in GBRICS. Adrian, was my understanding that today's policy considerations were focused on sustainability, but is that something, financial sustainability, is that something you think we want to save for a future agenda or have that discussion now?
It is something that policy-wise we definitely need to be considering when you think about how the comprehensive call center needs to work. I did not include it for today, but I'm happy to talk about it. I'm sorry, I'm echoing a bit. I don't know if anyone else is hearing that. Okay, I seem to have stopped there. One of the things that's a policy consideration, so we didn't put it on the agenda today because Dan and I were kind of more focusing on some of the kind of bigger bucket policy things. The other kind of policy consideration that Diane's referring to is how we have providers utilize the care traffic control software infrastructure, which will be really important for the effectiveness of the call center to be effective, for the call center to know the resources that are available at their fingertips. So I kind of think that might take a deeper dive conversation, Nikki, and it's something we should maybe put on the agenda for the next meeting.
Okay, makes sense. Any other thoughts on sustainability, financial sustainability? Oh,
Nikki,
go ahead, Dan.
I was going to ask one more question. To the extent, I was going to ask what your thoughts were on whether the call center, I know that other grants had talked about similar things and it might, you know, become a broader concept beyond our 5 jurisdiction area. Because one thing that the HSCRC does do is they put in pass-throughs for things that they deem to be social good. So it takes it out of the hospital's hands, right, out of the payer's hands, and just puts it on to the general calculation of the balanced update. So if it were that the care traffic control center were to become a statewide good that paid off, the HSCRC might just build it. You might be able to advocate that they build a portion of it into just its general pass-throughs, annual pass-throughs of hospital rates. That becomes more appealing as if it were to sort of broaden to cover the entire state, for example.
Thanks, Dan. Diane?
So Dan had asked the question about other sustainability strategies, and I think about just lessons from other states or other places that have implemented something like GBRICS, and the savings that were realized in other arenas. For example, I want to say the CAHOOTS program in Oregon, they actually get funding from sort of public safety because they share the savings that are realized. by the police officers, for example. And so they're actually, I don't know if it's city or county. I'm not sure how the funding structure works in Oregon. But as was raised earlier, the fact that there are any number of other organization types or stakeholder groups that can financially benefit from improvement in how the approach is used. Just throwing it out there, Dan had asked about other ideas, but consideration of where savings might be realized in other arenas where there could be some cost sharing or savings. Yeah, sharing of savings.
Thanks, Diane. Other thoughts or comments? Okay, great. I know this is not the last time we will discuss this topic, but it is important that we sort of keep this front and center. I said, in 5 years, we will be thinking about how do we fund this model long-term. So it's important. I'm sure we'll be visiting this many, many times. Next on the agenda is an update on the committees and work groups.
Hey, Nikki, do you mind if I ask one? Echoing again, I'm sorry. Do you mind if I ask one quick question of the council before we move on, just to help with giving us some direction at BHSB with how we move forward with thinking about policy?
Sure thing.
So one question we have for the council, so as the council knows, one of the things that we'll be doing for GBRICS is figuring out what the policy agenda is that we want to be advancing to sustain the project, since that's one of the things we put in the proposal we said we would do. I've heard some of the conversation this evening, being how the RFP for this proposal was the scope of services with crisis services. We've committed to setting up and expanding a couple of key service components through GBRICS, like the call center, expanded mobile crisis, and the same day access, and doing and sustaining some of those components, even though we recognize they're not, it is certainly not the full continuum of care, and it's certainly not the continuum of crisis services, but standing up and sustaining those kind of three components is a tall order. So when the council thinks about a policy agenda, do you have thoughts on how we should approach development of that policy agenda? Should we focus, should we be focused really on those several components and be thinking about policy strategies that support those three components? Should we approach that first and then look at other crisis continuums that are just as important, or other services that are just as important at a later point in time? Thinking about this question would help us a lot as we think about the proposal proposal for the policy agenda we want to put in front of you in the coming months.
Adrienne, it's Maria. I know this is late to the party, but as I look at the committees that were created to support the work, I almost wonder if there should be a separate, and maybe this can be just a separate group, not even necessarily of just folks that are on the council, but maybe even an advisory group of folks that can get together and have conversations around sustainability and some of the policy options there. Because I do think that there's obviously a lot of different options, data requirements that need to be assessed and evaluated. And there's complexity there that would really benefit from a group of stakeholders separately having a conversation about it.
I think that's a great suggestion.
Other thoughts to Adrienne's question?
I was just going to mention, this is Chuck. I was just going to mention too that one of the things that's missing out of our proposal that we all agreed was important was this, and that it's a part of the crisis model, is the subacute stabilization centers. And so whether or not, this is a great group of people to sort of advocate for direction, even if it's not a part of our primary, the grant. So I just wonder, we should at least keep that into consideration, that is a piece that's missing from the model right now as we're constructing it. And maybe we have an opportunity to kind of continue to push that forward too.
Adrian, one way of, that's a hard question you asked, really, because you don't want to make our agenda so broad and overwhelming. And I guess the way I would cut it in my mind is, outside of the 3 elements that we're working on, what are the biggest potential threats elsewhere in our systems to our successful achievement of our goals in 5 years, and then figure out what those elements are, and perhaps have a way of expanding our focus there, so that we don't get into a whole scale fixing everything that's wrong with behavioral health in Maryland and America.
Any other thoughts or comments?
Hey, it's Sharon. I'm going to be very embarrassed if somebody already said this because I had to step away for like 2 minutes. But from a policy perspective, did anybody mention access just to behavioral health providers in general? Meaning, some of them aren't accepting. There's a lot of them, they don't accept insurance assignment. Easier access to them from insurance providers. If nobody said it, I'll say it.
Thanks for saying it, Sharon. Any other thoughts or comments? I do agree with Linda that I think our focus has to be like, what are the barriers to success? What are the, really focusing on that I think that has to be the first priority.
This is helpful feedback. I could tell you our policy team was generally thinking the same, but we wanted to, get this feedback from the council first before moving forward. So this is helpful. Thank you.
And another comment in the chat is that workforce recruitment and retention could be a barrier to success. And I will tell you, I have heard that both internally and externally. So great point. Okay. I think next item on the agenda are the committee, GBRICS committee and work groups.
Yep, so not much to say here because the work groups have only just started meeting. So the brief update is that all of the work groups have had their first meeting. The Community Engagement Committee met in April, in the very beginning of April, and is planning to have its second meeting this week. They are in the process of looking, they've elected co-chairs and are now in the process of looking at principles of trying to figure out how to focus the work. The Comprehensive Call Center Work Group and the Mobile Crisis Team Work Group both met for the first time this past month in May, and again is just getting started and starting to figure out core service values for each of those different service components. And then the other just quick update I want to make sure everyone's aware of is that we did release the first RFP for GBRICS, which is the Community Engagement and Communications RFP, to identify a vendor to work with us on the project of developing an education campaign, market research and an education campaign.
And Adrian, I believe you've probably presented this in a timeline to us before, but I can't remember. When is the approximate timeline for an RFP around the care traffic control system?
There are kind of two components for that. There's the software technology, which in the proposal we identified Behavioral Health Link as the vendor we would work with. BHSB is currently in the process of developing a contract with Behavioral Health Link. We hope to have an executed contract sometime by the end of this month, but I will definitely keep you posted. That would be a big update when we do. And for those who aren't familiar, the software technology is the infrastructure that will help support that comprehensive call center. An RFP for the comprehensive call center will be something that we'll be looking to develop through that call center work group over the course of this year. We want to have input into the input and from the call center work group partners on what are some absolute things that we need to make sure that we have with our comprehensive call center, and those would be requirements that we would bolt into an RFP.
Thank you. Anything else on work group and updates? As far as updates, our next council meeting is May 10th. We are sticking with the Monday 5 to 7 timeframe. And wanted to open it up to the group to see if anybody else from the GBRICS Council has any updates they would like to share.
Did you just say May 10th is the next meeting?
Yes, May 10th.
That's what it says on the screen, but it's actually, I think, July.
Oh, today's May 10th. Sorry.
But it is what it says on the screen.
You're just trying to see if we're paying attention, Nikki. I
Actually,
gotcha.
clearly I wasn't paying attention. Clearly I wasn't. I was like, yeah, May 10th. It's COVID time warp. I don't even know what time, what month we are in, or year. Sorry about that. There we go, July 12th. Sorry about that. Any updates? Anyone, any updates from anyone else in the group? Is today the 10th, by the way? It is, right? Yeah, okay. Thank you as always for your time and your participation. I know your time is precious, and a Monday evening's you know, a significant commitment from everybody. And I'm thinking I might sort of close every meeting with a reminder that we have one chance to do this right. We will never see this level of investment in behavioral health services likely for a long time. And so we have one opportunity to do it right. And so your participation, your engagement is so critical in making sure this is a success. And so thank you for your time, and thank you for your commitment. And I know that we are all going to be part of something that point of time when we can look back and say, this is when we really did something to improve access to care for people experiencing a behavioral health crisis. So it is a very exciting to be part of this collaboration, and really appreciate everybody's commitment to this. Any other thoughts or comments before we end? What do you get? 14 minutes of your time back? Okay, thanks everyone. Bye-bye.
Thanks, everyone.